Great. Thank you very much. It's a real pleasure to be here, and I thank the organizers for inviting me on behalf of not only UC San Diego, myself, but also SCI. And I've been extraordinarily impressed by the quality of the people that I've met already and the work that's already being done here. And I hope as this society continues to expand and mature, we continue to work together on behalf of SCI as well. So I've been asked to talk about the randomized controlled trials, and after Bob's very elegant state-of-the-art, I'm going to take us back a little bit. And before I start, these are my disclosures. And the reason we're talking about this is this represents, bifurcation lesions represent almost 20% of the PCIs that are done. And at least in the bare metal stent era, they were associated with high failure rates, acute closure, and high restenosis rates. So drug-eluting stents were felt to be a great savior, as they have been for most everything else in interventional cardiology. And so the idea was that we would have improved long-term patency and address acute closure as well. It's already been discussed, the various classifications that are there, but pretty much the Medina classification is the one that's used widely today. And I'm also going to show you two cases. I'm going to start with one case, and this is the case I want everyone to be thinking of as I review the data. This is a circumflex obtuse marginal bifurcation lesion involving the ostium of the OM as well as the proximal and beyond the OM circumflex lesion. Both vessels were wired, balloon angioplasty of the circumflex, cutting balloon angioplasty of the OM. This is the result after the balloon angioplasty. Stent in the proximal circumflex at a moderate pressure. Things look like this. The OM is still patent. The OM is rewired and a high pressure inflation in the circumflex. And this is our final result. So as you think about this case, this is the left approach. This is the single stent approach with provisional stenting of the bifurcation branch. And some people also refer to this as the simple approach. And I'm not sure it's always simple. It's all relative as to what's simple and what's complex. So it's the single stent approach where you stent the main vessel and you provisionally stent the side branch. In general, if you look at the clinical trials, it requires one or all three of these things: impaired coronary flow, less than TIMI3 flow, a dissection of type B or greater, or a residual stenosis of at least 50 to 70%. In contrast, you have the two-stent strategy, where a priori you plan to put two stents in the main vessel and the side branch, and there's a whole host of techniques which I'm not going to talk about. When we're trying to balance out in bifurcation lesions, do we use the simple or single stent or the complex or two-stent approach? It's a balancing act between the simple stent approach is faster and of lower cost, use less equipment in general. The complex strategy or the dual stent strategy, the basic idea has been that you cover the carina of the side branch, so it should translate into lower restenosis and lower long-term MACE. And so it justifies the higher expense and longer procedural cost. So keep this balance in mind as we review the data. The first major study that addressed this in a randomized controlled manner is the Nordic bifurcation study. Just over 400 patients were randomized to the single stent versus the two-stent approach. It's a multi-center, 28 centers in the Scandinavian countries. Essentially, an all-comer inclusive trial. STEMI patients and left-dominant left main were the only exclusions. The side branch was 2 millimeters or greater. Main branch had to be 2.5 millimeters or greater. And there was provisional side branch stenting for the same three criteria that I talked about: impaired flow, residual stenosis greater than 50%, or a type B dissection or greater. But the data were surprising in that at 6-month follow-up, the MACE rates were comparable: 2.9% with a single stent and 3.4% with a two-stent strategy. In the single stent or simple approach, only 4% of the patients required a bifurcation stent. So the provisional stents were used highly infrequently. Keep that in mind. In the complex group, It was a combination of crush in half the patients and then culotte or T-stenting in the rest. But the big surprising finding was the peri-procedural MI rates were substantially higher in the two-stent approach. And I've shown that here graphically. So on the left is the price you pay, an 18% peri-procedural MI rate with the two-stent approach versus 8%, while on the right side you see the 6-month MACE events. All of the classic revascularization events and the combined MACE is comparable. And in the single stent approach, you can do this with less stents, less procedural time, less contrast, and less fluoroscopy or radiation time. At the same time as the Nordic study, the British always like to do their own studies. So they had a parallel British bifurcation study, and similar 500 patients, as opposed to just over 400, randomized to the single stent or the two-stent approach. In the single stent, you can see on the left side, very few patients, again, about 4%, required a provisional stent. In the two-stent approach, it was a combination of crush or culotte, 2/3, 1/3. The big difference between the BBC and the Nordic study is that peri-procedural MI was included as a MACE event. That's the only real study definition difference. The other difference is the side branch stenosis had to be 70% or greater to get a stent. What are the findings? Once again, you can see the MACE rates are better with the single stent approach. And on the extreme right, you see that the target vessel revascularization or restenosis with both strategies is the same. So what's the difference in MACE? It's primarily the peri-procedural MI. That's what drove the MACE difference. And in this study, once again, it was achieved with less fluoroscopy, less radiation, less contrast, and less balloon and stents used with the single stent approach. The data from the Nordic and the British study were put together at the individual patient level for this meta-analysis. And in this meta-analysis from these two trials, you can see that death MI and target vessel revascularization at follow-up is lower or superior with the single stent and provisional approach versus the planned two-stent approach. The difference is driven by a primarily procedure-related myocardial infarction, and as you can see at the bottom, the target vessel revascularization with both strategies is the same. And Dr. Applegate showed this just a few minutes ago. The simple or single stent approach was superior regardless of the anatomical differences or the extent of plaque within the side branch or parent vessel. Now, people remain controversial about whether or not peri-procedural MI is even an issue. That's been a debate going on in the field for almost 20 years. But I think this is a very recent publication from CCI just a few months ago. And what this study shows is in all bifurcation lesions, patients who have a peri-procedural MI have a significantly greater one-year mortality than when they don't have a peri-procedural MI. This is obviously not randomized data, but data that you should take into context. And on the right side, what you see is the large peri-procedural MIs are the ones that are primarily associated with much higher mortality. As far as much longer-term follow-up, Nordic has 5-year follow-up that's published, and what you see is that the simple or single-stent strategy remains comparable at the 5-year time point with the dual-stent strategy, and in fact, at the bottom, when you look at overall mortality, not cardiac mortality, and all MACE events, the single-stent approach at 5 years turns out to be statistically superior to the two-stent approach. So based on these two large randomized trials, I think what I can say with confidence is this balance between the simple or single stent approach against the complex or two-stent approach is clearly shifted in favor of the single stent approach. It's a faster procedure, less radiation, lower MACE rates when you take into account peri-procedural MI, and lower cost. In contrast, the two-stent or complex stent strategy is the one we all like to show at every major meeting, and I'll show a case here that I think is the only way you could have treated some of those patients later on. But the patency rates in every single study seem to be very similar with the single stent and provisional approach. There is some criticism in the sense that the complex approach is not heterogeneous. There's a number of different techniques, and let me show you some data upcoming here in randomized manners, which looks into comparing the various complex techniques. Before going on to that, when you do use the provisional approach, one of the questions that has always been there is, do you have to finish with a final kissing balloon inflation? This is now not with a planned two-stent approach, but with a single stent approach and provisional bifurcation stenting. The Nordic group tested this in a randomized trial where every patient received routine bifurcation kissing balloon inflation at the end of the case versus selective inflation, and it turned out that the routine bifurcation kissing balloon inflation was not necessary because long-term outcomes were comparable at 6 months. Antonio Colombo did the Cactus trial, very similar to the other studies I've shown you. 350 patients randomized. The big difference here is this is a Cipher stent. I should have mentioned earlier, BBC was SACIS while Nordic was Cipher. In this trial, same way, main branch 2.5 millimeters or greater, side branch 2.25 millimeters or greater, and all of the two-stent approach patients here were treated with a crush. So at least the approach was consistent versus a provisional T-stent approach in the single stent strategy. The differences turned out there were none. Whether you looked at late loss, whether you looked at restenosis, or overall MACE rates, the two strategies yielded the same results. The difference actually was that there was no difference in periprocedural MI as opposed to the previous trials that I've shown you. So now, as opposed to Nordic and BBC, we have a trial that shows that there's no difference in periprocedural MI, but there's also no difference in the MACE rates. And I have to give credit to the Nordic group because they continued to evolve and they continued to test all of the different things that we are practicing today in bifurcation stenting. And they randomly assigned patients to the crush versus the culotte technique and reported no difference in 6 months with respect to overall MACE rates. But in fact, the crush technique was associated with higher restenosis, main vessel, side branch, and both. It did not reach statistical significance, but the restenosis rates were higher. However, the culotte technique was associated with higher stent thrombosis. So I don't think you can unequivocally say one is better than the other. One leads to slightly higher restenosis, the other leads to higher stent thrombosis rates. Overall, none of these studies, now this is an important caveat, none of these studies are adequately powered to definitively answer these questions. Longer term, crush versus culotte, comparable outcomes. Now I'm going to move forward to a couple of studies that have been presented at meetings, but I've yet to see the actual final manuscript, and so I think you have to take this with a little bit of grain of salt. S.J. Park and group from Korea have designed two very elegant studies. The left is called CROSS, the right is PERFECT. The idea on the left side for the CROSS studies is side branch stenosis or the absence of side branch stenosis, so lesions that don't involve the side branch. You stent the main vessel. If there is pinching of the side branch, you get randomized to no further intervention versus a final kissing balloon. On the right side is the PERFECT trial. The idea here is upfront 50% or greater side branch stenosis, and you get randomized to the crush technique versus kissing balloon and the tap technique. This is the CROSS, what I showed you on the left side. Primarily, the left three Medina classifications of bifurcation lesions were enrolled in this trial, no side branch disease. In the PERFECT trial, you needed to have side branch disease with the parent vessel involvement. Just over 900 patients have been enrolled. I won't go into the detail, but I will share with you the results, which is when you look at the CROSS, this is no side branch disease up front. If you finish with final kissing versus no final kissing balloon inflation, results are comparable with respect to 6-month MACE. On the right side is the PERFECT, when you have upfront 50% or greater side branch disease, and you use crush versus the tap provisionally, again, no difference. So I've shown you a lot of data, a lot of randomized data, and not a single study would suggest that using an upfront two-stent approach is the way to go. But here's a gentleman who's 74 years old. He has an unprotected left main. It's a left dominant system, so his right small, and he has an ejection fraction of 35%. He has both a distal left main, as you can see on the right side, as well as a diffusely diseased LAD, and it's a bifurcation lesion that also involves the ostium of the circumflex. Now, obviously, this patient should go for surgery, which he didn't want to go for, and so we were going to treat him percutaneously. This is what his angiogram looks like. Because of his LV dysfunction and entire myocardium at risk, this is the cranial shot. We went ahead and decided to put an Impella device in first, and then we did rotational atherectomy of the distal left main into the proximal LAD, an ostial LAD, rotational atherectomy throughout the mid-LAD, stented the mid-LAD, stented more of the mid-LAD, and then when we did this angiogram here to look at the distal left main, you can see that there's an ostial circumflex and an ostial LAD. This was stented with bifurcation stents, simultaneous kissing stents, I should say, from the distal left main into the LAD and circumflex, and final kissing balloon inflation. And this is what the angiogram looked like after we were done. And so the point I wanted to make is this type of patient was not included in any of the randomized trials that I've presented. So when the side branch is 3 millimeters or greater, there are a few such patients that are represented in the clinical trials, but they are a vast majority. Or not a vast majority, but a majority. And Dr. Applegate, again, talked about this. This is, I think, a little bit of where the new direction might be going. So when you look at the double kissing crush technique, and again, I'm not going to talk about the details of the technique, but when this technique was randomly compared against the provisional approach, this is the first randomized controlled trial that would suggest that a planned bifurcation stent technique might actually be superior. What's different in this technique? 370 patients enrolled in 7 Asian centers, but the big difference is they included main and side branch vessels that could be 2.5 to 4 millimeters. All the previous studies, the side branches were anywhere from 2 to 2.5, sometimes 2.75. Here you have large side branches, large parent vessels. They also limited the trial to true bifurcation lesions, not a mixture. These had to be Medina 111 or 011 only. They used the Excel drug-eluting stent, DK crush versus provisional. Provisional stenting was in 28% of the cases, and they were able to do final kissing in the provisional group 79% of the time and 100% of the DK crush group. And you can see that TLR, TVR, and MACE were superior with the DK crush approach. And this was without paying the price of higher peri-procedural MI, but at 1-year follow-up, MACE is barely, but it's lower, but it did not reach statistical significance, but target lesion revascularization did. And this is the final study I'm going to show you. It's still in press, and this is the DK Crush 6. The reality is it's still called the DK Crush because it's the same group, but this is not a DK Crush. What they did is, in a very elegant manner, looked at a group of patients who were all going to get provisional stenting. So bifurcations treatment with a single stent approach, but they randomly allocated patients to an FFR or angiographically driven decision to do provisional stenting. And when they did that, what they've reported is no difference in MACE, MI, or TVR with FFR versus angiography, or what we get to see visually. And they also reported the restenosis rates at follow-up in this DK Crush 6 study. And what you can see is that when you look at the side branch specifically, there's really no price to pay by using angiography alone versus FFR. So I've shown you 7 randomized trials. So shared a lot of data, but I thought I would quickly go through the main takeaway points. The Nordic trial is single versus double stenting. MACE rates are same, but the safety and simplicity with lower peri-procedural MI favors the single stent approach. The BBC, single versus double, MACE rates actually were in favor of the single stent approach because peri-procedural MI was included as an endpoint. The Nordic technique was really to look at culotte versus crush. The two techniques lead to similar outcomes. The Nordic kissing balloon was to figure out whether or not when you have provisional stenting, do you need to finish with a final kissing balloon inflation? And the answer is you don't need to. The cactus is crush versus the single stent approach, and what you see is overall MACE rates are comparable, but the single stent approach is favored because it's simpler to do. The DK Crush 2 is the first randomized trial showing superiority of the DK Crush versus provisional stent approach, and finally DK Crush 6 showing no difference between angiography versus FFR approach to bifurcation provisional stenting. So in conclusion, I think based on the current data, bifurcation lesions are clearly better treated with the single stent approach with provisional sideband stenting. The provisional sideband stenting has ranged from 4% to 38% in the various trials. The one stent approach leads to lower peri-procedural MI, less contrast, less procedural complexity. Overall clinical outcomes with the provisional stenting approach with respect to long-term MACE are comparable to the two stenting approach. Final kissing stent balloon inflation is critical, though, when you use two stents because it lowers long-term stent thrombosis. And finally, large bifurcation lesion stents where the side branch is 3 millimeters or greater probably needs a lot more investigation in the future before we say that those group of patients also are better treated with the provisional approach. Thank you very much.